All right, Jesse, if you would pull up the results for us, please.
Great. I'm just going to go through these quick. Physician reimbursement under Medicare Part B is generally 10% of you said going up, 10% said going down, 50% said is flat, 20% said depends on specialty, and 20% unsure. Interesting. If enacted as proposed, value-based arrangements will, 40% said create new partnership opportunities between physicians and hospitals. 30% said create new incentives to take risk in management of targeted patient populations. And 10% evolve and reduce regulatory burdens in physician-hospital relationships. 40% stress the control environment over tracking, reporting, and monitoring physician arrangements. 20% all of the above. So thank you for answering those, and thank you, Jesse, for pulling those up. So to get us started, today I'm going to turn things over to Eric Rogers at BKD. Eric.
Hey, thanks, Kate. Good to see everybody again today on our last week. I've got two fantastic gentlemen going to help walk us through a discussion on provider implications. You know, some of it's very specific to COVID, but we also want to talk about some of the other changes that have been happening here recently. They're going to have quite a disruption. Large health systems as well as small rural hospitals like yourself. The first I'd like to introduce is Mark Blessing. Mark Blessing is a managing director at BKD and has been with the firm for a long time. Before that, he was a CFO of a hospital organization. And Mark is one of our true leaders in our performance advisory team. He's based out of Fort Wayne and has been helping hospitals in the Delta program, specifically with Kate and Shannon and Brooke, over the last few years. And I know some of the folks that are on the call today have worked fairly closely with Mark on some specific TA projects. I know Pema Scott knows Mark and Randy pretty well. So Mark, thank you for joining today. Happy to hear from you. And we also have Randy Biernot. Randy leads our Physician Services Center of Excellence out of our Indianapolis office. And Randy has exclusively worked with physician groups and hospitals and their physicians that they have either employed or contract in some manner on strategies, arrangements, and deals that are win-wins for both organizations. And the team that Randy oversees gets into a lot of the regulatory updates as well and how that impacts those deals with doctors to try to look for the results and the patient care that your organizations need. So Randy, thank you for joining today. The two topics that we're gonna cover from Mark and Randy, if we'll turn the slide, are going to be provider compensation and COVID-19. We're going to talk about past, present, and future. If we go to the next slide, Mark will cover that. And then our other agenda item is going to be a 2020 outlook that Randy's going to cover on reimbursement, regulatory, and more. There are always lots of questions that come up on the physician services side. So we want to encourage folks to either unmute and ask questions as we're going through, or type in the chat box some specific questions that you may have, and we want to be able to address those as we go through. So without further ado, Mark, I'll go ahead and turn it over to you.
Great. Thanks, everybody. And you can go ahead and advance the slide, Shannon. Next one, please. Lots of friendly faces and names. So very excited to see everybody, at least virtually. It's the way we're working now, I guess. So I'm thrilled to be here, to be able to talk to you. And I always apologize for my picture at the start. I look at that and I think, wow, I look young, which is absolutely tragic when you have a good picture like that. So I apologize for that. But I am going to take the first part of our discussion today, and it is going to be focused on what's going on from a provider compensation standpoint, and it is focused on rural providers, and very much we tried to aim the comments at, you know, what we know of your operations and what we're seeing around the country, and certainly within the work that we've been doing in your facilities. And I am going to put a flavor of COVID in it as well, just kind of what's going on, you know, currently with COVID as it relates to physician comp. And then Randy will jump in and give you some really important things you need to know about what's changing in Medicare reimbursement in the future here from a physician standpoint. So I'll get started. And again, I would reiterate, happy to answer questions as we go. You know, you don't want to hear us droning on probably. So happy to have questions as you go. So basically, my area is touted as physician compensation, provider compensation, past, present, and future. And so I'm going to start past, and not so much past, but just kind of what have we seen, where are we at historically? And I think that if I were sitting in your shoes, I'd probably at the end of this slide say, thanks a lot, Sherlock. You figured out all the obvious things that are going on. But here are the things that we have talked with a lot of rural providers about. So you might get a sense of that you're not alone, maybe at least. Certainly from a compensation level standpoint, you know, it is very difficult to align compensation levels with the productivity that's possible in your market. So, you know, you are recruiting with all other providers for physicians, and they don't necessarily, there isn't a rural provider pool. They can go, providers can go anywhere, and so they look at that market. So you're really in a, while it may have some of, you know, may have some effect, you're in a national market to an extent, and so really don't get a discount for being in a rural setting. But you know, productivity and making that compensation work is difficult in a rural setting, and so you're really struggling with that. And we have lots of clients that struggle with that, both from the standpoint of business and just keeping, you know, enough throughput in practices. And then if you have enough business, then you start worrying about, well, maybe we need two. Or they get a little bit too busy, and can we afford two? So that gets very difficult. And then also your payer mix frequently can be a challenge. And so for all of those reasons, you know, it's hard to align being able to recruit physicians and make it work financially in a rural setting. Specialty care really almost, you know, on top of that, of all the things we just talked about, also, you have the entire technical element of that going through your hospital. And so, again, you know, specialists are more expensive typically than primary care. You know, you also have to be able to deliver the technical services within your facility, typically. And lots of times that's the strategy you're using, but you want to be able to deliver that service within your facility. And so, again, you know, productivity, market share, you know, the scope of services to be able to do that in a way that you could do it efficiently in your facility and in your market are difficult. And so specialty care, especially in a rural setting, can be a real challenge, and really generally creates the third bullet here, which is we despite this, we have seen a trend. And this is, you know, in urban hospitals as well as rural, but we have definitely seen a trend over the last 5 to 10 years of employment of providers by health systems, as opposed to, you know, I think in a lot of your situations when we have talked to you, it really, a lot of your physicians might have been independent, or might have been part of an independent group historically that was in your town or in your region. And, you know, it just became hard for them to make it based on, you know, reimbursement not improving for providers over the last 10 years and just everything going on. And so, you know, we have certainly seen the trend of providers being acquired or hired by hospitals in a rural setting. And when that happens, what really heavily occurs is significant losses can accrue to the hospital. And so, that bottom line, that subsidy loss is a significant issue that lots of rural hospitals are dealing with, but feel they have to do it because otherwise, physicians are kind of important to being able to run your hospital. So certainly understand why, but that has been a challenge. Offsetting that challenge, we have seen rural providers very aggressively use designations, especially Medicare designations such as rural health clinic, critical access hospital status, aggressively use provider-based program designations, and other similar types of things. And if you're not doing that, we would heavily recommend you take a look at that. That can be tremendously beneficial. Although you'll catch in my third slide here that from a value-based standpoint, you're probably going to have to think about something going forward. But right now, I think it's an extremely important thing to do, and I think most of you are doing that. I would also add that the 340B program has been a very significant finding and benefit for a lot of you. The provider-based, the rural health clinic or the critical access status really will aggressively put you into that 340B program benefits, and expanding those benefits are something you might want to think about, even if some of these other designations don't help you that much just in straight reimbursement. So that's kind of where you have been, or at least that's what we're seeing a lot of our rural hospitals, kind of the situation they're in from a physician comp and subsidy standpoint. If you go to the next slide, Shannon, let's go into present. And a couple of things that are happening right now that are we think are very important. The first, let's talk a little bit about COVID. So, COVID has had a dominant effect on our industry. And certainly I know you guys are up to your eyeballs with COVID. I think we're all sick of hearing about COVID, but wish it would go away, but it will not. So, or at least hasn't so far. So the first area from a physician compensation standpoint that we have been dealing with heavily, and really almost all providers that employ physicians certainly have been dealing with, is how to handle idle time. So lots of providers might have been idled. If you have specialists, they might not have been able to do elective surgeries, other things like that, or at very least, you might have had a very significant downturn in activity. Since most or a lot of your providers are probably have a productivity element in their compensation formula, lots of providers have had to deal with, well, what do we do with those providers? Do we hold them harmless? Most of the providers believe you should, I think. But, there's been a wide range of handling of that. I would ask Randy to jump in here as he's dealing with lots of these issues.
Thanks, Mark.
Yep.
So, yeah, I mean, the providers are under contract, so to some degree you have to follow what's in the contract. But for physicians more than probably the nurse practitioners and things, those contracts are often set up for a base and some type of productivity bonus. So the question is, well, what happens with the productivity bonus? Does that really turn into like a loan of some sort? Do you change the thresholds? So what we have seen most, I mean, it's hard to have a most on this, but we had a survey of about 50 organizations, and generally about a quarter of them really did nothing. And so whatever the compensation plan said, they just followed. And so if that meant that their providers took a hit potentially to their second or third quarter calendar year bonus, then so be it. A handful of them wanted to mitigate that effect. So probably half of them lowered base draws so that the bonuses wouldn't get out of whack. And then a quarter of them did something I just call more aggressive, more direct contracting, where there's really just sort of a temporary or an alternative compensation plan for their provider. So probably, again, a quarter did nothing, a quarter did sort of a new or temporary comp plan, and then there's a middle batch that sort of did mitigating. There's probably half a provider. So I don't know if that sounds consistent for you all or not, but that's generally how provider compensation was coped with during this period, and really probably more driven by cash flow management and sort of economic needs than say a regulatory fair market value imperative or anything else. Obviously, there's a desire to work closely with your highest paid employees to make sure that they're not surprised and things like that. But probably the overriding concern is just financial, because of the, just the terrible economic impact of the whole thing. So, Mark, I don't know if that's answered kind of what you're hoping for. If you have
I appreciate it. And just so you know, I mean, that's, I'm sure you're dealing with this in some way, shape, or form if you're employing physicians. And so there isn't one size fits all. And there's been a wide range of how to handle these things. Kind of associated with that, two things to think about from a COVID standpoint. I think most of you probably have received significant funding from the HHS Provider Relief Fund, and potentially some of you might have gotten PPP loans and then other funds that have come in. One of the things for you to think through is, the documentation that you're going to have to put together to be able to retain those funds. And we would see that provider compensation and kind of the effects on providers may be a significant element of supporting that. Certainly from a PPP standpoint, those rules are known, and likely you're going to support a significant element of your PPP loan with what you've paid your providers. But from the HHS standpoint, once the rules become clear, there may be an element here where the way to support your use of those funds was in paying your providers. And so I would keep my eyes open for that information. Right now, we've only been told, it's lost revenue or additional expenses, but really no guidelines as to what specifically documentation is supposed to be put together. And so we will certainly try to get that information to you, and we will certainly be watching for that guidance coming. But again, I think a lot of it, your payment of your physicians, especially when they were idle, will probably be important. The second or the third point is, if you didn't get a PPP loan, you do currently have an opportunity to get what's called an employee retention credit. So if you had idled physicians so that they were, and again, idled there's not a lot of definition behind that. So the idea behind it is that it's not just that they were unproductive or their productivity went down, but it is related to that. So it doesn't mean they had to be at home, playing Yahtzee or anything. It would be basically if they were not as productive, not as working as hard, basically, as you would have expected them to be in a normal situation, and it's related to a specific governmental order. So, couldn't do, there were PPP issues, PPE issues. There were, electives that we couldn't do, other things like that. If you're in that situation and you didn't get a PPP loan and you're not a governmental entity, you should look into the employee retention credit. You basically would accumulate that information, and probably your physician compensation in those idled elements is what will support a part of that. You can get right now a credit of up to $5,000 per employee, and it's $10,000 of idle time that you paid them. And really what we're finding across the country is that if there was idle time that was paid to providers, it's typically the physicians. They're salaried, but they were slow. So that might be a really good opportunity for you. So if you believe you're in that situation, we'll be happy to talk more about that.
So Mark, because of the small format, I might maybe just pause to see if anybody falls into that bucket, because I do think it's really valuable. So if you think that you're non-governmental and you had a government shutdown and you didn't get PPP, so those three things, maybe put yes in the chat, because the spirit of this CARES Act was essentially, if you're keeping personnel on the payroll, including your doctors and whoever, really, you're keeping them on the payroll, but they're not really doing what you'd normally have them do or to the full degree, it's a credit to make up for that. So you're not, so there's some incentive not to lay folks off, furlough them. So if that's if that describes you, there's some real money to be had there. And so again, if that's no one, though, we can move right along.
Yeah. I see your comment about governmental. The reason that governmental doesn't apply is simply because in the CARES Act that was passed, governmental hospitals were not included in that. I assume there's some great political or governmental reason for that, but wasn't anybody's great, not our idea, but it is specifically excluded. A governmental entity is specifically excluded. Unless you potentially are a dual status, if you have your 501c3 status, that might be an opportunity for you. We're not quite sure about that, but we don't think you're completely eliminated. And I think you could probably make a case that you could file for it. Couple of other points here from a present standpoint. The first, talking about the E&M procedural changes and kind of the changes to the work RVUs within the Medicare physician fee schedule that are coming in 2021. Randy's going to talk about this. I won't hit on this very much other than to emphasize, listen closely when Randy tells you that the work RVUs for E&M procedural work are going up, but reimbursement is not. So if you have a compensation plan based on work RVUs, this could be a significant issue for you. You could end up with the same money coming in and paying your doctors more. So Randy will explain that more. I just wanted to emphasize it. The last thing here, and I'll talk a little bit more about this in future in the next slide, but in essence, what we have seen from an incentivization methodology in the current fee-for-service environment that has been effective, we think, for a lot of our rural providers is, I think that from a compensation standpoint, the winner over the last 10 years has been productivity, and work RVUs is kind of the gold standard that everybody uses to basically say, well, we need to incentivize our doctors. We can't just have them come in here and expect, to work for a salary, because we need to incentivize them to remain busy. Being an old CFO of an orthopedic practice, I would tell you that there really, there's revenue, and, if you look at subsidies, there's revenue and expense, and both of them are important. And so I completely agree with the productivity elements to make sure that doctors remain busy. But what we're seeing is trends to include more of a subsidy thought process, or more of basically a bottom line, or involving the doctors from an incentivization standpoint in the cost of delivering care as well. That's really where they were at when they were independent. And so doctors, when they're independent in a practice, you would be amazed what overhead hawks they are. And when one doctor wants another nurse, how they get on them. I bet that might be helpful for you when you're trying to manage those situations. And so that would be an area of incentivization in a fee-for-service environment, that involving the doctors or having them have skin in the game from the standpoint of not just productivity, but really bottom line. How do we do bottom line, and what expenses are we generating to generate this productivity? I think is a very good place for you to look if you're trying to control subsidies, and where we have seen probably in the last year or so a lot of movement from the standpoint of adding things to compensation plans that are straight productivity based.
Mark, there's this, make a comment here. So there's several of the hospitals that are on today that are critical access. And, there's that notion out there that has made it into the physician community that, oh, we're a critical access hospital, so the cost doesn't really matter that much. It's all going to be a wash on our cost report. So if I've got, 2 nurses and 2 MAs and a receptionist in my practice, and everything I want, that all that cost gets factored into our rate and the settlement there. So what's your recommendation, to those organizations that are critical access hospitals, and how to have a more meaningful and accurate conversation with those doctors that say, we're critical access, cost is not an issue?
That's a great question, Eric. And what I would say, a couple things. One is, you're getting cost-based reimbursement on an element of your activity. It's not all your activity. And there's a significant part of what you do that you're not cost-based reimbursed. And for those, you can't just really say, well, it doesn't matter. If you're 50% cost reimbursed, it means you're 50% not. And those subsidies, I'm sure everybody's looking at their bottom line and sees those subsidies of employed physicians. Those are being generated because you are not 100% cost-based reimbursed. Number two, lots of times those costs get kicked out of cost reports. It's a dangerous area. A lot of costs may not be totally covered. Depending on what type of RHC you have set up, there are all kinds of strategies to try to get as much of that cost covered as possible. But it's a dangerous type of expense as opposed to more, more practice expense or hospital type expenses that typically don't get offset. Physician costs frequently get offset, which means you're not getting that cost-based reimbursement. Okay. I'll just kind of lead this into the next slide, if you would, Shannon. From a future standpoint, one of the driving, and this is again to get to Eric's point, one of the concerns with our structure from being able to get cost-based reimbursement, which is why we can afford some of the difficulties that we talked about from a past standpoint. One of the real key risks we run in a rural setting from a value-based reimbursement change is kind of that effect. Because other people are going to be looking at us, from a value-based standpoint, and if it costs us more to deliver care than the same care does someplace else, then we may have referrals that are sent away from us aggressively because of that. And so, there are in an ACO setting. I don't know if you've been involved with ACOs. I know some of you have, and I know maybe some of you have dealt with that. There are ACO providers out there that aggressively tell their rural providers, get out of your RHC, because everybody's looking at that and saying, well, costs, to do an office visit in an RHC setting because it's cost-based reimbursed is much more expensive for an ACO than it is to send them to a non-RHC setting. And so therefore there's going to be negative selection for you. By the way, we would heavily tell you, don't get out of your RHC unless the ACO is driving 90% of your reimbursement. So I'm not suggesting that. But if you look at the future from a physician compensation, provider compensation standpoint, value-based reimbursement comes into play. There is a concern that you're going to have negative selection of your facilities because you're a critical access hospital or because you have this RHC setting. And so it's always a good idea to try to be as efficient as you can going forward. So there's a lot of reasons why you want to remain efficient. From a value-based standpoint, just from a physician comp standpoint, I would tell you that outside of really the idea of involving the doctors now fee-for-service in kind of bottom line and getting them interested in their expenses, is from a value-based standpoint, there are other things that drive reimbursement. And productivity, while it remains important, as I say on this point, it's not nearly as important to reimbursement in a value-based setting as it is in a fee-for-service setting. And so because of that, there are two other things that are incredibly important that are driven by physicians, driven by providers. One is efficient patient care management, and the other is quality outcomes. So it's just the whole outcomes data, how you keep track of your patients, case management. Coding is a part of patient care management because you need to correctly identify patients. All of those elements that a physician has involvement in are things that you may want to start thinking about incentivizing them because they need to start paying attention to them if value-based reimbursement starts coming into your market. So, as looking at physician compensation plans, if you asked me where you need to start looking to kind of change, again, I would move away from, or if you're going to move away from productivity, straight productivity, I would start looking at trying to get an idea of care management, trying to get information, and there are, you get information from a MIP standpoint on the care management abilities of all of your doctors. That is data that you have access to, that we could talk you through and show you where it's at. Outcomes data, same thing in MIPS data. It's something that you can start looking at and getting in front of your doctors. And you're going to have to try to figure out how to do this if value-based reimbursement comes into vogue and gets to be 60, 70, 80% of your activity. And if it does, I do believe that there will still be rural health benefits from a reimbursement standpoint. I don't think that RHCs and critical access hospitals and all the things will go away, but I do think it'll change. And again, I wouldn't want to be relying on those designations in the future in a value-based world. And again, from a productivity standpoint, it's important. But frankly, in a value-based standpoint, the doctor, the orthopedic surgeon that hasn't met a hip that doesn't need to be replaced is the last doctor you want. In fee-for-service, it's absolutely the doctor you want, as long as it's medically necessary. But in a value-based situation, if you were 100% value-based, that's you want somebody that's really good at managing care at a low cost, because you're being paid the same amount irregardless. And so so totally incentivizing doctors on productivity isn't a good answer in the future if this comes into vogue. Last thing, and then I'll turn it over to Randy. Some other trends are honestly to kind of reverse this trend towards employing physicians, because number one, lots of providers will employ physicians because we need them. We need physicians in our market, and those are real reasons you have to do it. But if you're doing it to kind of get control of that physician or their operations, that's a hard thing to do. I don't know that the strategy of getting control of the doctors by employing them is the same as everybody else that kind of does what you tell them to do. Doctors aren't that great at that. The other part of this is that, and to get back to the bottom line of subsidy, entrepreneurial spirit in a provider is incredibly important. And them understanding that they make money or they lose money based upon how you do is something you should foster. You should give them information. And to the extent that you move them into affiliation arrangements, or if you have a doctor that wants to be employed, talk to them about, why don't you keep your practice, but we'll help you. We'll do certain things. We'll pay you for call. We'll do things like that. That leaves the entrepreneurial spirit. The bottom line is still the doctor's responsibility. And so they will respond as you would want them to respond if they were your employee. And so that really is something that is occurring. And we believe that it much better can control losses, and really aggressively getting to affiliation as opposed to employment is something that you should consider the next time that you're looking to strike an arrangement with a doc. I'm going to turn it over to Randy now to give him some time to be able to talk through his important section.
Thanks, Mark. Yeah, and unfortunately, as opposed to wanting to be more independent, what I've heard is, this COVID situation has really been more, hey, I can't make it anymore. Can you help me out? So I don't know if anyone's heard that or much of that, but it seems to be going around. So Shannon, if you advance the next slide, we'll get into this kind of 2020 and really kind of future outlook. Through my career, there's never been more happening in the physician services space. So my 18th or 19th year, there's never been more going on that affects physicians. So we don't have time to spend, thoughtfulness on each of these points, but all of these things are happening. They're either true or happening or market forces. And any one of a handful of these things would be important, but just a handful is this physician fee schedule change, which I'll talk about in the next few slides. But that's a really big deal. The fraud and abuse law changing, that's a really big deal. I think that'll happen between now and the end of the year. The last time there's a big Stark law change, it was a 3-year event, the so-called Stark 4. The Stark change in 2008 was a big deal. This one's going to be just as big, honestly. So there's a Stark law change coming. This fee schedule change coming is a big deal. This price transparency push is a big deal. All the telehealth that's been accelerated. You know, we've got 5 years of growth on telehealth in 2 months with the onset of coronavirus and all the loosening and waivers and so forth. So so again, any one of these things would be a big deal. But when you start to put some of these together, there's really going to be some big changes. And one of the big ones that I think will affect rural providers in particular will be the combination of the change in fee schedule, the change in fraud and abuse laws, and the change in the telehealth. So in the new fee schedule that's proposed, I saw some headlines that said, oh, telehealth's permanent. And while on some level telehealth is here to stay, I agree with, I don't know that it's permanent, but they did extend the waivers. They'll run at least through, or they extended the effect of the waivers for these telehealth services. They'll run at least through the end of calendar 21 and potentially beyond. They've set the stage for that. So Congress needs to act to really do true permitizing of telehealth, and that's been floated in some of the acts that are out there. But clearly a concrete step in that direction. So again, you put those three things together, and I think what's going to become available is a level of specialty care rendered on a telebasis into your facilities that just is not affordable today. So I've got big health system clients with a spoke and hub model that are pushing telebehavioral health or say neurology or stroke care because they can afford to based on their scale, or again, just based on margins, they're able to afford those kind of services. They're basically not reimbursed, or they're reimbursed very poorly. I think what you're going to see is with a change in more permanency and eventually permanency in some of these telehealth reimbursement standpoints, there's going to be a new opportunity to render care locally through tele that just isn't available now. So Mark talked about cost of care and the cost of providers. It's cheaper to hire a doctor in Chicago than it is in Rensselaer, Indiana. Okay, if you haven't heard of it, that's why I mentioned it. And so you're going to doctors like living in Chicago, and that's great. You got these big groups up there that really aren't making more, and they're living in a high cost of care, or cost of living, probably cost of care as well, settings. They're going to be able to sell their services all over the country. And you're going to take these big groups of providers, and they're going to be able to manage stroke patients, and if it's getting reimbursed, it will be a game changer, really open up doors. So again, there's probably 10 of those off this one slide, 10 of those kind of connections that can be made, but private equity is going to fuel a lot of that. There's just an incredible amount of money sitting on the sidelines, concerned that the stock market's in a bubble, and with, close to zero interest rates, there's a lot of pressure to do something with that money. So again, if you have not spent much time thinking about what's going on in the physician world or what might be changing, truly, I think momentous times in the physician space. But I do want to spend a few minutes on the reimbursement, something more tangible and short term. So Shannon, if you would please, let's go to the next slide. Let's blow through this one too. I mentioned probably enough about what's on here. All right. So Mark alluded to this at the beginning. What Medicare has done, I know many of you are reimbursed on a cost basis, and that's fine. But if you have specialty clinics that are billed under traditional fee-for-service, this will matter. And even if you don't, it might matter because of your compensation plans. But basically, Medicare Part B is a closed system. There's only so much money in the pot. And then what happened in this proposed rule that came out last Monday, the prior Thursday, so about 10 days ago, is there's now a big RVU inflation that's happened. So these 10 codes on screen represent about 20% of Medicare expenditures under Part B. And on average, they're going up 25%. And so again, it's kind of wild to think that 20% of all the money under Part B goes out under these 10 codes, but that's how it is. And all these codes just got inflated with no new money. So the impact of that is that the conversion factor is dropping 10%. There's never been a proposed 10% change like this, except when you go back to sustainable growth rate, which is always a joke to really not get fixed. It always got fixed. This is just no joke here. I think this is going to happen. And this is CMS from a policy standpoint saying we value primary care, we value behavioral health services. And so they pumped in a bunch of RVUs into the system. And so because there's no more money, the conversion factor went down. So for primary care types, that are using these code sets, there'll be an increase in reimbursement net. Because again, there's not less money, and there's definitely winners and losers. So there's going to be more money in primary care. So to Mark's point about, groups are going to be able to stay independent or maybe go independent, there should be more Medicare money out there to do that under this proposed rule change. The other side of that, though, is that there's less reimbursement now going out for all the medicine and specialty care. Anesthesia took a 10% whack. There's a bunch of downward pressure because it all ends up net neutral. So on the right-hand side of the slide, Medicare also changed codes in these areas because they're set in relation to these E&M services. So like an OB bundle for maternity services. Basically, CMS said, yeah, those types of visits are very similar. We should increase values there. So if you have providers in any of these areas, they'll be affected probably by net positive increase to reimbursement a little bit. Everyone else is getting a decrease, again, under fee-for-service Part B. Shannon, let's go to the next slide, please. Okay, so this is going to increase. So we think that there's likely to be, an increase in subsidies because of how many providers are paid based on work RVUs. So if, again, under a traditional fee-for-service model, if half of your book of business, your net patient service revenue rather, is Medicare, and you're going to get a 10% cut to that, you're going to have that's going to hurt your margin. The real issue is not the reimbursement side, though, again, especially if you're an RHC, it's your compensation. So many compensation plans are set in reference to the current year Medicare fee schedule. And unlike the reimbursement side, where it's only, it's only impacting your Medicare fee for service, on your provider comp side, it's really all the RVUs. So again, if you're on this call and you have any providers that are paid in reference to work RVUs, and they're using those code sets we talked about, you're going to have an increase in compensation. And that increase might increase the subsidy by $40,000, $50,000. That's the level of increase. These, again, we don't need to go back to the prior slide, but those established patient visit codes, levels 2, 3, 4, and 5, they're going up like 28 to 43%. Okay, so if you're a pediatrician, after that first baby visit, everything's pretty much everything is an established patient visit. So you could have a pediatrician's RVUs go from 5,000 to 6,500 on the same number of visits. If they're in a RVU-based bonus plan, there's 1,500 more RVUs that are likely in that bonus zone going out at $50 an RVU. And that's not really a hyperbolic example. That's the kind of thing we're talking with our clients about. And so one of the key takeaways, I think, from this whole, from my whole webinar at least, is in the short term, it'll be really important to evaluate any contracts you have with providers, whether employed or independent, that reference the fee schedule, because of these work RVU value changes being so dramatically different year over year. So Shannon, maybe go to the next slide, please. In terms of sort of what to do, this is kind of the short list of, gosh, if you're going to give, a clerk or a manager some direction on, hey, what do we need to do here? Partly want to understand, well, what are we trying to accomplish? It's like, hey, we don't want to lose any more money or spend any more money on doctors, 1. 2, what goes into their comp plan? 3, gosh, if these changes go through, and there's some coding changes as well, as you probably know, what's really going to happen? And so if we have reimbursement, let's say it's down 2% or 3% at a group practice level for your specialty. Okay, that's easy enough to understand. Well, what happens at the provider comp level? If everybody's on a salary, this doesn't mean very much to you. If everybody's on a work RVU bonus program and generally earn bonuses and are, again, you're generally users of those code sets, the new and established patient visits, you're going to have an increase in cost that the government's sort of pushing on through this plan. I don't think it's their intent to do that. I just don't think they have any awareness of the impact. And so again, here's just a brief walkthrough. Next slide, please, Shannon. I know want to have time for questions. In terms of what you can do to think about different plans, okay, RVUs aren't going to work, fee schedule is going to change. The finalization of the fee schedule is not going to happen potentially until as late in the year as December 1st for a January 1 change. What do we do in the meantime? So, a handful of options on the screen, which I probably won't talk through, but thinking about maybe that second bullet point, some of these corridor clauses, it might make sense to have, a real heart-to-heart with your employed medical staff and say, gosh, we have a major change coming in the fee schedule. We cut deals with you all that we think are fair and reasonable and affordable for us. That Medicare is changing the counting system of RVUs doesn't really mean to us that you're underpaid. This is really for independent practices and getting them more reimbursement. We've already marked you to market. Instead of getting the $36 in RVU you were in private practice, we're paying you 42 or 45, 50. What Medicare is proposing to do in this fee change by changing the RVU values, they're really changing the score system. And so they're again, inflating RVUs that, doctor, that we don't have money. We're not going to get anything else for it. We think your $300,000 in compensation for last year for about the same work effort was fair. Gosh, for your protection, for your benefit, for ours, if things go up or down, let's try to leave comp about the same. And so some of these corridor clauses can be simple ways to have an honest discussion with a provider about, we've already struck a fair bargain. If you're working about this much, you should be getting paid about that much. And let's basically keep it that way to the extent possible. Let's control for that year over year. For you all, I would think strongly about that type of conversation so that your subsidy doesn't go up $50,000 in 1 year. Because again, once that money starts flowing, it's very hard to turn it off and very hard to walk it back. And honestly, it's hard to afford. And so I know we're at 10 to the hour, and I do want to maybe stop here and see if there's questions or conversations. But we're just going to, again, it's not good news. I apologize, but there is, there's time now between now and the end of the year to get in front of this stuff, and you certainly want to get to it prior to January 1 when these changes start happening. So I'll leave it there. Thank you, Eric.
You bet. Mark and Randy, really appreciate your comments there. I am curious to hear, obviously everybody's in a situation where they've got plenty of providers in the organization to navigate and communicate with, but number one, I want to make sure, was everybody aware of the kind of the proposed and the increase in the work RVUs there and staying up to date? Mark and Randy, where should they be going to, is there a CMS site? Is there somewhere that they can go to make sure that they've got the most correct and up-to-date information?
Yeah, so the CMS website, it's not great, but there's a lot on there. So that's where we're going daily, really to look for postings and new information. Okay. If someone wants, so we have an alert on this, we had a webinar. If someone wants to email through, we can send that back out. We spent an hour on this topic on Monday. If you're interested in more, that's out there. We can share that out.
Okay. What kind of dynamics, Randy, do you think are going to come up? More and more organizations are getting aggressive with mid-levels and extenders doing more work, particularly as you bring up those E&M levels. a heavy portion of that in the rural hospitals is taking place in the rural health clinics by nurse practitioners. A lot of times those contracts are set up as a salary. You know, they may be making $90,000, $100,000 salary. What if I'm a practice manager or CFO at an organization? What does this mean to my relationship with my mid-levels?
So if they're on a salary and your cost reimbursed, you know, you could have slept through the last 20 minutes. I don't think that's a big deal, kind of on a short-term basis. On a long-term basis, from an affordability standpoint, my recommendation is to try to find providers who want to be a boss, and just set an expectation that physician, you're going to come and you're going to work here and you're going to see patients 3 days a week, and 2 days a week you're going to collaborate, and you're going to be responsible for supervising 4 mid-level providers. That's the kind of ratio you need to be sustainable, 4 to 1. That's aspirational. You know, maybe 1 doctor, 2 APPs is the best that can be done. But trying to find providers who want to serve in that way, I think is really important. So I've got friends and clients at some of the biggest health systems in the country, and even they struggle. They can afford to hire whoever they want. They can pay whatever they want, and pay isn't the issue. Pay is important, and you'll hear anywhere between 1/4 and half of, you know, satisfaction or the lure of a job's pay. But I mean, it's culture. It's wanting to be in a community. It's wanting to be in a place. If you say it's just money, that's who you're going to attract, honestly. Just seen it repeatedly. If you can get providers to buy into mission and buy into the community, you're way better off. And you're going to need to pay a certain amount to get folks there. But I think part of that mix should be, hey, we're going to deliver care a little differently in our community. You're going to be the point person for a team of care. And I'm encouraging all my clients, even not even in true rural, but in just smaller cities, you know, 50, 100,000 population type county hospitals, to bake right into their contract, bake right into the expectations that you're going to supervise at least 2 mid-level providers, because from a sustainability standpoint, you kind of need to. And then with restrictions in immigration, it's hard to get providers kind of in the door right now, and that's a challenge. MedPAC, I think, it reports out that there's a huge, just explosion in nurse practitioners, and from a supply demand standpoint, and just from an economic standpoint, it's good business. Get a doctor that wants to collaborate, pay them for that, and you'll be a lot better off financially.
One thing I would add is, if you have specialists, we've seen a great variation in how APPs are used. And we would strongly tell you that there's a tendency for specialists to use APPs like part of the staff. They're not seeing other patients. That is a very, very expensive nurse. And so, supervising an APP for a specialist doesn't mean that they take them on, around on their same visits. They need to be seeing other patients.
Randy, I know that your slide where you were kind of showing your graph of subsidy was an example. And the number that you had listed kind of as the starting point was right at around $300,000 of a subsidy. I'm just kind of curious from the group, are hospitals right now doing a subsidy analysis to set a baseline to know, from a primary care standpoint or from a specialty standpoint, we are at an average of $200,000 loss, and we're hoping we're making that up through the admissions to the hospitals and referrals, or are we today at 400,000? Do we know where we're at? So that kind of be my question to the group is, who all out there is doing some type of analysis to find out what your current situation is on profitability of your practices?
Not everybody at once.
Okay.
Well, the one thing I would suggest is it's a really good exercise to go through. As you know, we kind of talked about understanding that bottom line, understanding what that subsidy is costing you. And that's hard to tease out when you have an RHC and other things like that. We understand, but really tracking that and understanding it will give you a lot of guidance from a compensation standpoint and how to better manage physicians.
Okay.
Well, we're waiting to see if there's any thoughts or questions coming in. I think Shannon had some post-polling questions too, so maybe she could pull those up while Eric's still talking.
Sure.
You guys could take a minute to fill out the post-poll question. That would be greatly appreciated. Sorry. And I did see a comment come in from Lisa at Henry County. Lisa Castillo, we track each practice individually. Only in the RHC do we have positive bottom line. Others are specialty clinics and do not break even and are subsidized.
That's very consistent with what we would see across the country, especially in a rural setting.
Do you share, Lisa, do you share any of that information with your providers to kind of give them a reference point in terms of the commitment that the organization makes to them in their practice, or is that all just kept internally within management? Well, she's kind of responding. Kate and Shannon, Brooke, the Delta team, we appreciate you helping to facilitate these meetings over the last 5 weeks. Appreciate the opportunity, and we thank all of the hospitals that have participated with their teams. We hope that this has been educational and beneficial to you and your teams. For those that are coming up in the next cohort, we'll be working with you and can field other questions. But if there's any questions that have come out over the last 5 weeks that you feel like one of our subject matter people may be able to help you, feel free to shoot me an email and I'll get you connected with them, and you can have a phone call. They'd be tickled to talk with you a little bit further. So Kate, thank you for the opportunity.
Yeah, Eric, Mark, Randy, thank you so much for today and for the last 5 weeks and the whole team at BKD. These have been extraordinarily educational and useful. I know I've had some of the sites reach out for the recordings because they were sending them to more people in their facility to make sure that they were able to listen to them as well, and we're really appreciating them. So yeah, thank you all for joining us over the last 5 weeks. Again, if you want to have those ACHE credits, just reach out to anybody on our Delta team. The recording for this will be sent out. Centerville will send it out, and all of the recordings are also on our website, the Delta website. And then I was just going to ask BKD, I know you had mentioned that you did a webinar on Monday with those, I think it was about the work RVUs. If you wanted to send us that link, Centerville could just include it when she sends everything out to the listserv. And that would be great. If anybody has really specific, any of these technical questions, I really encourage you to reach out to the BKD team. They're just excellent subject matter experts, and we lean on them heavily for all sorts of stuff all the time. So with that, I just wanted to bring up Lisa's comment. We do share this with all our providers. We discuss the practice, strategies, new services, etc.
Thank you. Have a great